Thank you, each and everyone, for joining us for the next session. Today, we'll be starting the first. So we have a few sessions specifically on pain and as well as pain management. So today we'll be touching upon an introduction to pain. And today we have Dr. Radha as our faculty. Dr. Radha is an anesthetist by training, and she was working in Saudi Arabia and in UK for many years. During this period, she was involved in anesthesia practice, intensive care, as well as teaching medical students. And she has done a lot of work in chronic pain management, running chronic pain clinic few days a week. Then she has worked with the palliative care unit in Adyar Cancer Hospital, Chennai. Right now, she is in UK and she's taking the sessions from there. Thank you so much, ma'am, for joining us from there. Thank you so much for agreeing to be part of this program. So these are around 40, nearly 40 doctors from various parts of the country. Welcome you, ma'am.
Thank you very much. It's been a pleasure and a big thank you to TIPS Pallium and the whole team. And it's a pleasure to be part of your team. And as Dr. Sridevi has mentioned, we'll do a concise recap of introduction to pain. And to some element of it will be on to help with the palliative care aspect of it also. So is it okay to start the presentation directly, Sridevi?
Yes, ma'am. Yes, ma'am. Please.
Okay, just a minute. Can you all see the screen?
No, ma'am.
Okay, then wait a minute. Oh, just.
Ma'am, do you want us to screen share from our side?
Radha ma'am, can you confirm if this is visible?
Yes, it's visible. So will I be able to control it, or how will it work then?
I will control it from this end, ma'am. So you just have to intimate when you have to change the slide.
Okay. Thank you very much. Okay, well, welcome to all. And as we have said, it'll be an introduction to pain will be our main topic. And can I have the next slide, please? Like in July 2020, the definition of pain, a revision to the definition of pain was done by the International Association for the Study of Pain. The main thing why they did this was the initial definition was done in 1979. And then after that, they have had a 2-year collaborative consideration of many factors. And this new definition was done with the main idea that the nuances and the complexity of pain is conveyed in such a way that the assessment and management of pain is dealt with appropriately. So the current definition is, what is pain? Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by the addition of specific 6 keynotes and the etymology of the word pain. In this definition as such, every word has significance and importance, which we all have to have in mind and which will be dealt with in the next 30 to 40 minutes or so. Next slide, please. Okay, the main 6 factors what was mentioned is that these are the 6. Pain is always a personal experience. We also have to have in mind it has the social, psychological, and personal elements also to it, which have significance. And next is pain and nociception are 2 different important elements which have to be understood properly. pain as such is a complex phenomenon. Nociception is just the receptor level or how the pain is perceived. Then comes the life experiences, which do have an important role, which as we go through our session, which we will come to understand. And then comes the expression of pain needs to be respected. We just can't ignore, oh, it's nothing, because it is a subjective opinion, but has to be given consideration and respect too. Next comes pain usually is said to have an adaptive. See, always it's said to be a protective phenomenon, but to some extent it can become an adverse phenomenon also. And then the last thing is that verbal expression is not the only way to express pain. So by this, what they are coming to say is if someone is not verbally expressing, that doesn't mean that there's no pain. So that is something which has to be considered. Can I have the next slide, please? Whenever we describe pain, we have these factors or features to be considered. Where is the pain? What type is the pain? And to what extent? Are there any specific aggravating or relieving factors present? And whether there is any impingement to anyone's routine day-to-day activities. Next slide, please. Next, coming to the pathophysiology of pain. What I've given here is a diagrammatic representation of the physiology of pain, in which I'm going to just give an overview only on this, because if we go into this, we won't have enough time to go into the other elements of it. So that is why I've given a diagrammatic representation in which you have the nociceptive information part, where the nociceptors itself can be of different types. For example, in the skin, it's a different one. In the muscle and joint, you have chemical mediators and also stretch receptors type of thing. So then comes the mediators, then you have the dorsal horn, and then you have the spinal cord, you have the ascending tracts, the brain, descending tracts. So in total, the normal physiology. So that is, we are all aware of this. So then we will go on to the other pathophysiology of pain, which will give us an overview and an idea on how are we going to understand this to help us to manage it also. Next slide, please. Coming to the pathophysiology of pain, the mechanism per se by which a damaging stimulus in the body is perceived as painful one by the brain is a complex one. Why is it complex? The complexity is there because of the nervous system not being a hardwired system. It's not a fixed one, but it does exhibit plasticity. This is the important thing which needs to be understood. This is what enables it to modify its function under different conditions. And then pain serves the purpose, as I said initially, to prevent tissue damage and protect the body. But under certain conditions, this pain can become maladaptive and persist as chronic pain. When it happens like that, when pain serves no protective function, but becomes a pathological one, it then becomes a disease on its own itself, which we need to have in mind. Can I have the next slide, please? Okay, now coming to the various type of modulations which happen, the pain modulation mechanisms. From here is what is the important thing. See, it is just not a simple one, but understanding this will help us to a very great extent to look at pain in a different perspective and look at various options of management and things. So the various modulations are categorized under at least 3 different headings. The first one would be a peripheral sensitization. What actually happens? When there is an initial injury, at the time of injury, there is a resultant inflammatory mediator released. And this release in turn causes release of further interleukins and prostaglandins. So as a result of various prostaglandins and mediators released, there happens to be an inflammatory soup type of reaction. This is something which is very, very important because this is what results in exaggerated pain response. So in any thing, the mediators as such, it is not one or two, multiple mediators are released and in turn causes extra release. So the resultant one, which is said as the inflammatory soup, has a big load of mediators there, which need to all be metabolized and taken care of. So that is why the pain persists, which is one of the important things. So if, for example, what happens, it's not a quick response. So because of the persistence is what is one of the reasons mainly for chronic pain initiation and persistence. So peripheral sensitization is an essential thing to be borne in mind. Next slide, please. The next comes is central sensitization, which is an increase in the excitability of the dorsal horn, so that the dorsal horn cells have a lower threshold and respond to low intensity stimuli itself that are not usually painful. So central sensitization is also another element which, because of its per se action, which is a non-stimulus or not a strong stimulus to have a intense pain, can be made to one of that kind. Next slide, please. Next comes the neuropathic element or the neuropathic pain. This arises following disease or injury to nerves from a number of etiologies. It could either be an ischemia or a trauma or an infection. So see, it is just not trauma. So any form of injury to the nerve. I would also say not direct injury, shear and stress, which, for example, there may not be a direct injury, but there may be for example, if you take surgeries, there may not be a physical cut to the nerve, but when something is done, the resulting or adjacent nervous structures can be just had some shear or strain. That also can result in any of the neuropathic pain modulation things which could happen. So that also needs to be borne in mind. And the etiologies which are given here, especially ischemia, trauma, infection, those are the main factors which are the reasons. Like, for example, diabetic neuropathy is a very well-known thing. And that in that neuropathic pain forms a big element. Next slide, please. We will go in a little bit more detail into the mechanisms or why or how this neuropathic pain mechanisms happen, because these are the main cornerstone or the reasons for which, by which this pathophysiology is significant for us to understand. And then in turn, everything in turn is going to help with management. So the various mechanisms which are responsible for the neuropathic pain are, I'm going to give you a very simple, not in detail explanation of each, but the first one is a spontaneous ectopic discharge. Normally, there needs to be a stimulus every time to have a electrical firing to cause a neuronal response. But what happens when there is an injury, as we have seen, one of the injury due to any of those etiologies, whether there's a direct nerve injury or so, that in turn, once the injury happens, after that, there may not be a response. Spontaneous ectopic discharge happens as a cyclical phenomenon. So the first injury itself may be sufficient to trigger further spontaneous discharges causing the pain. That is one mechanism. And the second one is known as altered gene expression, by which in this particular mechanism, what happens is some degeneration, Wallerian degeneration is said to happen, which in turn can lead to downregulation or upregulation of the neuronal structures and the stimulus, and in turn can lead to spontaneous ectopic discharge. And then next comes involvement of the sympathetic nervous system. The injury may not be directly to the sympathetic nervous system at all, but being adjacent, we know all these structures are not miles apart. They are all very close by to each other. So an injury of one nerve can result in some involvement of the sympathetic nervous system also being adjacent. A common thing which all of us see is whenever there is an injury, there may be also additional features like edema, pseudomotor or vasomotor changes. For example, in CRPS, we are aware that there may be color changes, there may be sweating, there may be temperature changes. When you see the site of injury and adjacent structures, maybe just that part, if you compare it to another part of the body, that part may be hot or cold. So these sympathetic changes are present just because of the involvement of the sympathetic system being adjacent to the site of injury. And next comes collateral sprouting, which is a phenomenon seen in crush injuries. One common example is crush injuries where you have, and this collateral sprouting is sensory sprouting of the nerve fibers, and things can happen in those types of injury. So these are some of the mechanisms which are the cause for the neuropathic pain features. Next slide, please. Then comes central sensitization. What happens in central sensitization? The central mechanisms potentially involved in the generation of neuropathic pain are thought to result in neuroplastic changes. So this is the reason for central sensitization. Can I have the next slide, please? In central sensitization, the main two mechanisms which are said to happen are wind up and central sensitization. Basically, what happens in wind up? To make it very simple and easy to understand, it is like amplification. Basically, the same stimulus, it may be a stimulus to cause an X amount of pain or X amount of stimulation, whereas that X is multiplied into few or amplified. So a small stimulus, small response can be amplified to a very great extent. That is what is wind up. That's why, as I said, it is because of the plasticity nature of the nervous system. So both wind up and central sensitization are similar. That is, amplification happens. But in wind up, it's a short lasting phenomenon. Whereas in central sensitization, it is a long lasting one. So they are also mediated by NMDA receptors in the central nervous system. But whether it is a short lasting one or a long lasting one, whether it is a wind up phenomenon or a central sensitization phenomenon. So these two are the main central sensitization mechanisms responsible for the neuropathic element of the pain. Can I have the next slide, please? Now we come on to the various types of pain that we are all aware of. First one is acute pain, which happens or present at the site of injury, mediated by nociceptors. Chronic pain next. This is related to pain in conditions such as I mentioned before, diabetes mellitus, arthritis, and tumor growths, etc. Next comes somatic pain, which is generated by nociceptors in deep tissues. Visceral pain. What is visceral pain? Visceral pain is something which is present in deep viscera, like the gastrointestinal pain, etc. Next slide, please. Next comes neuropathic pain, which we have seen to a great detail on the mechanism, and which is caused by damage to nerves, resulting in increased firing. And the next few symptoms are important to understand mainly, so that we are aware of terminologies. For example, allodynia. What is allodynia? Allodynia is pain resulting from a harmless stimulus. For example, what do they try to convey here by harmless stimulus? Something which should not cause pain. Common or a very well-known symptomatic example would be patients who have neuropathic pain will have pain to touch, which is not a normal phenomenon. If we all were supposed to have pain to touch, we will not be shaking hands with each other, isn't it? So that pain to touch, which is a harmless stimulus, can be a very significant presenting symptom. Similarly, another common complaint or presentation would be some patients would even complain of a pain to the clothes touching them. So only when you see such patients and when you are aware of these basic physiological or pathological phenomenon which can cause all this, that will help you to a great extent to put 2 and 2 together when you see patients. So allodynia is one of a common, very clearly distinctive symptom or presentation of neuropathic pain. So pain to touch and pain even when clothes touch them. So that is one of the important things which would be helpful. And then next comes hyperalgesia. This is like a normal response. It is an exaggerated response to a normal stimulus. If something should create only mild response, in that place you get a exaggerated maximum response. That is what is hyperalgesia. And finally, we have referred pain. Referred pain is pain which is felt in in an area other than the site of origin. Commonly, like myocardial infarction pain, like sometimes you feel the pain in the arm, neck, throat. That is one example. And another common example would be like nowadays we do a lot of keyhole surgery. If there is some remnant air under the diaphragm, patients do complain a lot of pain in the shoulder. So I think if there are surgeons and anesthetists also, that's a common thing which we tell patients when they get discharged. So don't be worried, until all the air gets absorbed, you may have pain. So these are all types or examples of referred pain. Can I have the next slide, please? Okay, now we come to the final element. So we have seen of the pathophysiology of pain. Then how are we going to assess that, which would help us to manage it finally? So assessment of pain needs to be done with great patience, importance, and everything. As it was mentioned in the definition itself, we have to give important weightage to everything, what the patient says, how, and then measure it appropriately so that we are able to deal with it also adequately. Coming to the assessment of pain, there are valid and reliable assessment of pain for both clinical trials and effective pain management, because both are important. We need to understand what it is, and also we have to manage it appropriately. Acute pain and chronic pain assessment has to be done in its own entirety, because they are two different entities. We have to give priority to both and assess them also accordingly. Next slide, please. Okay, coming to acute pain assessment. As I initially mentioned, you do have like to find out the site of pain, nature of pain. You have in each center, they may have an appropriate, some people may have like a pictorial representation, because see, we have to deal with all this, like tailor making everything to your situation. Because we deal with patients from different demographics, and so we have to have a particular type of assessment tools which will meet your own criteria, requirement, etc. But the standard ones normally which are used are numerical rating scale. So you tell the patient, if 0 is no pain, 10 is maximum pain, where would you say your pain as? So that is one example. And you have the visual analog rating scale also from 0 to 100. Many studies have been done and shown that numerical rating scale and visual log rating scale match to a very great 70 to 90%. They say that they both go hand in hand. And you also have verbal rating scale, mild pain, moderate pain, severe pain. That also is something which is used. I have got a diagrammatic representation also to give you an idea how it would be. And the next couple of things which are used recently are dynamic pain assessment also. See, for example, when someone is not doing any action, they may not have any pain at all. But once you ask them to move or do something, they may express pain. So that is why dynamic pain assessment also is done. That is pain assessment on movements. And last comes the baseline pain assessment, which is also essential, because sometimes, especially if you go to start off itself, their pain maybe it may not be zero. So something like that to give us, see, this, as I mentioned initially, not only for assessment, or are we meeting our objectives and goals? When you measure outcomes, so that in that aspect also, the assessment part is going to help us. So if we have a baseline value, we would know whether after assessment and management, have we achieved our outcome or not? And then next, when we come on to the chronic pain assessment tools, from chronic pain point of view, as we have seen, it has got multiple elements in it. Multidimensional qualitative tool assessment is what is found to be useful. And there are also several disease and patient-specific scales also available. Each disease per se would have additional factors. Once again, I'm going to tell about diabetes, because which stage of the diabetes the patient is, that also will give us an idea, because to put things into perspective. So that is why we have diabetes, arthritis. You have additional assessment tools also, which have to be incorporated. And neuropathic pain, especially allodynia and things what we have seen, that also have to be mentioned. Whether there are any sympathetic symptoms additional on top of the pain. So looking into those aspects also are essential. Next slide, please. The general tools which are commonly used are the brief pain inventory, which has an idea of, as I said, site, nature, and type of pain, with certain factors or the features which we have mentioned all will be incorporated in that. And then you have the Meggle pain questionnaire, which again has a descriptive form. Each symptom, whether the nature of the symptom, and then whether each one is, because see, everyone may not express things in the same way, and they would have some specific ways of expression. So in that, you give more versatility to the patient to express. So in each one, you can again grade mild, moderate, severe. So we have a short and a detailed form. And then you have neuropathic pain assessment tools also available. And last but not the least is assessment of health-related quality of life in chronic pain patients also. See, again, few more changes are done, like as I mentioned, the tailor making. There are some standard forms available, and then you can also do translation, tailor make it to your need. You do a forward and backward translation so why do you do a forward and backward translation? Because we are having worked in Chennai also, because these are for example, the quality of life questionnaire, that is which is used, the European one is used very widely. But you can do, as I said, we took up that tool. We did a forward and backward translation. Why these translations are done? The forward translation is done so that you get to convey the message. The backward translation is done in the local language, for example, if you want. And when you do the backward translation, the end result will be, it will match the original form. So that rules out any bias or any queries in any, if there are, so that tailor making technique can be used, so that you get the best outcome for the local or regional needs also. So all this can be used in all the above mentioned things. You can use that technique and tailor make it to your own needs also. Next slide, please. And finally, coming to the cancer pain assessment. A major impact on cancer-related pain management happened after WHO guidelines for it was released in 1986. But still globally, relief of cancer pain is far from satisfactory. And they say one of the main reasons for it is still due to the non-availability of analgesic drugs easily. And still WHO and very many organizations are trying to make availability, then allowing people the opportunity and availability, or like sanctioning to have controlled drugs in local centers. There are many things being done, but still they say this is not, this feature of still non-availability is there in many developed countries. So still, that's why very poor level of satisfaction only has been achieved in that. Next slide, please. The common tool used in admin in cancer pain assessment is, see, when you are considering cancer pain, it is just pain forms a very big part of it. But the other mentioned factors here, for example, activity, nausea, depression, because these are the salient features in cancer patient. It is just not the pain. It is a drastic change to their day-to-day living. Anxiety score will be very, very high because so much of uncertainty is there. And appetite, for example, is a very salient thing. See, patient, the disease per se is going to cause loss of appetite, and the family or someone would be wanting to do everything, but we have to assess that and then teach them how to manage. So for example, what I've mentioned here, every element of it has significance and importance. So that is why all these form salient part in the cancer pain assessment. And the other well-being and shortness of breath, that is also, see, well-being, patient may have many issues and things. We have to help them in ways and means that the patient would find it comfortable. So everyone will have some element of positivity in them. We have to find out how their well-being is, how can we improve their well-being. And last but not the least, shortness of breath is a symptom. And in your course itself, you will know managing that to a very good extent by all the available measures with us now, we could give a better quality of life for them. Once you relieve that symptom, you will know what it, if you relieve that symptom, it might improve their anxiety, it might improve their depression. So by dealing with one, you may get benefit in the other parameters. So all these what I mentioned here are salient features or of assessment to be done in when you're managing cancer pain. And the other tools are what I've mentioned. There are the MD Anderson pain inventory is there, and there are also other specific assessment forms specifically for patients with dementia, patients living in their end of life care. So we have an extensive availability of tools for all these things. Can I have the next slide, please? As I mentioned, see, this diagram gives you an idea of the numerical rating scale, verbal rating scale, and the visual analog scale. So all that together given in one slide. So that, see, you have some for children. You can go on. There are umpteen stuff available, but we will use what is essential for our needs. Next slide, please. Okay, so why have I put these two pictures there? Finally, I would like to conclude with something. See, there is a standard or a very well-known statement. A thing of beauty is a joy forever. So in this last 30 or 35 minutes, we have seen pain is just not a neurological connection, afferent, efferent alone is not what is the cause for pain. So we have seen it has got so many other elements. So we need to understand the aspect. And as I said, a thing of beauty is a joy forever. What finally stays? So why have I put nature? Nature is one of God's creation, is a beauty always, and it lasts long, and that feeling stays in our heart. Anyone for that matter, I think all of you will agree in that front with me, that a thing of beauty is a joy forever, and all of us can and try to be happy all the time. So by this, what I'm trying to say is, if we have some goals as this, so end of the day, what we have to teach patients is that there is in management, which you would see in your further sessions, that recently what is practiced is something called as SMART goals: simple, measurable, achievable, which is time bound, have to be had in mind, so that we have to tell our patients in such a way that we know the pathophysiology, it has got all these components. So by teaching them something simple and reachable and measurable and achievable, and why I said time tested, you need not go on do it for short periods, and try doing something like that, and put these positive elements in your management will be really, really helpful to attain our ultimate goal of success in management. So that is why I thought it would be nice to conclude with something in a positive note, because by learning all this, it gives us an overview to deal with it appropriately. Thank you very much.
Thank you so much, ma'am, for taking us through the various parts of pain, starting from the pathophysiology and moving on to assessment and various types of neuropathic pain very specifically, because that's something that we all struggle to manage many times. And pain assessment plays a major role, because I think that's where everything starts from. So if your assessment is thorough, then the management will be better and the outcome will be better. Ma'am, there is a question from Dr. Jason. Is there a gender difference in perceiving pain? Ma'am, you're muted.
Can you just repeat the question, Sridevi?
Is there a gender difference in perceiving pain?
In the sense, general difference in what, like between the type of pain?
Gender difference, whether
gender difference. Okay. That's see, they say there's no 100%, but it is mainly said that women have like slightly higher. But again, if from what we have seen today, the psychological, social element is more from gender point of view. Women have a more impact on the psychological and social elements. So that is one of the factors for the gender difference.
Yeah, I totally agree to that, because even though there is a gender difference in some of the articles they mention, but it all depends on the cause of pain, the support system he or she has. So I still remember during the first days of my training, a doctor from Australia came to talk about it, and then someone asked about the labor pain. Then he told, if you have a healthy baby coming out, then your labor pain is okay, it's pleasurable. But what happens if some complications happens and the baby dies? Will that labor be pleasurable? No, it's not.
We do have, see, for example, like if someone has like a termination or something, you do 28 weeks, 30 weeks and all, it is very, they do give more pain relief, even sometimes appropriate epidural, if it is like later stage, is done. And so it does. So that's all, the outcome has an impact.
Yeah.
So
I
my
think
final slide is
of,
very important.
Very true. I think the meaning of pain is also really important. He was mentioning another example about people doing the piercings for the religious purpose. They don't feel any pain. But can we just
One
have
more thing.
just one pin? If you don't believe in such things, that's the experience is very, very different.
So see, exactly. And one more thing, what I had what I had on my other slide thing was gate control theory, which I like. That's what I had added that this morning. So that is one of the important mechanism. That gate control theory is something which is dealt in very great detail, because that is said to be the important reason that was studied and published in 1965 by Malzac. And the thing is that that is why TENS, everything by by stimulation through A beta fibers, and it is a non-nociceptive stimulation. Commonly, when we hurt ourselves, we rub of injury, and that reduces pain. For that, and the TENS machines helping in pain relief, the gate control theory is the important factor for it. And one more thing I would like to convey for the gender element of pain. They say, see, we said that gender, thank you, dear. So that's all. So this gate control theory is basically is an important mechanism causing inhibition. See, normally the C fiber in the picture what you're seeing, the C fiber stimulation is the nociceptive one, and the A beta is the non-nociceptive one. Just by stimulating through that, you stop. See the second picture, the gate is closed. So the pain perception this is one of the important mechanism for how TENS works, how rubbing or something causes pain relief. And this is the main strategy used in it. Can I have the next slide of this, please? See, the whole mechanism of how everything works is from opioids to the local, everything, this gate control theory is what is the base. So that is one part. And from the gender point of it, what I was trying to say was, there have been studies that see, because we said female gender, male, they have more pain, but they don't express it. In that also, some studies have shown, because like they are set, they try to be like, they are bold, they are brave, they don't want to express. So from that point of view also, some studies have shown male have the impact, but they don't express. So they may be suffering without expressing. So from gender point of view, both types have been mentioned, and everything else has to be. That is why, once again, assessment will help. So a true assessment, if you get, because initially, maybe first consultation, they may not reveal. Once you get a good rapport with the patient, your second assessment may show more information. So those type of things also have a role to play when you consider these things. So gender does have an impact. It will have both positive and negative impact can be. Anything else?
Dr. Svetlana, you had a question, you raised your hand. There is another question Dr. Shaleen is asking. Is gate control synonymous with mechanism of counter irritants?
Mechanism of counter irritants.
Counter irritants.
See, it depends. See, counter irritants is like is something counter irritant is used, and that will also help in the same mechanism. Yes. Well, let me check if there's anything else in the.
Dr. Svetlana, you had a question. You had raised your hand some time back. I couldn't call you then. I hope I am pronouncing your name correctly. Are there any other questions from any of the participants before we move on to the case presentation?
Sridevi ma'am, can we proceed? You are muted.
Yeah, I know. There is a background noise, so I was waiting for the ambulance to pass so that it's not disturbing others. There is another question. What is the basis of WHO ladder?
See, WHO ladder is to help us with the management of pain. That is all. So that, see, you don't start. Why do we use the step ladder? You don't start opioid for someone with mild pain. So to go on a systematic approach for pain management, that is the first and important basis. Because see, and we don't have box standard approach, and we all have individual variation. Don't always
General
think
surgery.
that you need to have opioid for everyone, because for example, the benefit, I have worked in 2-3 continents, as I said. See, what I've seen in India is that, like, because some are opioid naive, some are not opioid naive, so that has a big role to play. So following the WHO ladder is a very, very important thing. So multiple drug usage can be avoided, but by following that, by either in the step ladder 1 or 2 itself, you will get a pain reduction from a score of 8 to 2, then you won't need anything. So that is why the step ladder approach will be very, very helpful.
Ma'am, there is another question. Is there any standard
Because
format?
suddenly everything, I couldn't see the chat and things. Okay, go ahead, Sridevi.
Any
I was about to
standard
ask.
format, for eliciting history of pain, since it is a subjective phenomenon?
See, that is why, as I said, no, you have these basic, you take one of the any questionnaire, and you have to tailor make it to your regional need. There is no, I wouldn't say any, you use these basic pain inventory tools, and use it to your, because see, if you're not able to convey and get the message from the patient properly, it will not serve the purpose. So that is why, as I said, normally from the very many places I've seen, you have a pictorial representation, because even if someone doesn't understand anything and does not understand English or does not so you give them a picture and tell them to mark. That is something I think globally it is being used. You just draw a picture front and back, and you tell them to mark the places. Then you give them the intensity, severity side of thing. So by that, you're generalizing, and you're making it very clear and simple. Anything made simple is more important than complicating stuff. If you make it simple, you will get the best result.
Yeah, I would like to add, I've typed it in the chat. Here we follow the onset provoking palliating factors, the quality and severity and the temporal factors, along with what Madam was mentioning. The severity we measure in the numerical rating scale and in a body chart. So it's very important to, if they can mark the areas where they have pain, that's the best. Or we ask them, where are the pain areas? We mark them. And I usually ask them, is it the areas that you have pain? Is it the right, or you have pain somewhere else too? That's very important, because patients may develop new pains after 2 to 3 weeks. The initial pain was on the breast, and next 2-3 weeks later, they might have a neuropathic pain radiating to their arm, which was not there before. So it's very important to mark the areas, because we don't know whether they are talking about the same pain or different pain. And if you have multiple pain sites, what we do in the body chart is that we put it like A, B, C pain. Assess A pain separately, B pain separately, C pain separately, because all these pains can be different from each other. So that thorough assessment and documentation is the key for pain management. If you get a good pain assessment, then things are much easier. And there is another question from Dr. Nari asking for pain in a patient who is not fully conscious in ICU. How to assess pain in an unconscious patient?
Okay, from that point of view, you have the other factors, as we know, raise in heart rate, blood pressure response. We have the standard vital signs response. So by movement, grimacing, so even facial grimacing. So the same, what you have the score, like we do have for children and adults, whether they are happy. So facial grimace is an important thing. And then next is you always correlate with your heart rate and blood pressure. Vitals will have an impact if the patient is having pain. And the ICU pain that is how those are the factors which are used generally. Tear, you have many things like that. Grimace and tear are very commonly used, and the heart rate, blood pressure changes. The ICU, like you will see the like an arterial line trace you've got or something, you will see the rate change instantly. So that is the vital parameters. You correlate with that, and like that you will have for respiratory rate will be high. Every system wise you will have features for that. So I've just mentioned like 2 or 3 immediate ones, but you will have an entire system things also available if you go methodical.
Which scale we should use on OPD basis? Ma'am, could you hear me?
Yes.
Which can be on OPD basis?
So that's what the thing is that, as I said, no, there's no specific, you have to use this scale, that scale. As one of the important things, as Dr. Sridevi mentioned, reassess every time. Every time you see, I know it is all voluminous, too many things to do, but see, by reassessing, you gain 2 things. One is your own outcome you're measuring. Oh, the patient had this before, now this is how it is. So it is your own and also new things have cropped up. So if this was not there before, so I have to make sure that I deal with that also. So this any specific sticking to anything, I would just leave it to individual area availability. But standard is what, as we mentioned, you have to find out where, what type, and then any new. And then normally we do ask whether it is affecting their sleep, because by that, and then the next thing is you have to get some amount of their psychological, social impact of the pain on their day-to-day living. How they have been before in this 1 week, has this affected their day-to-day activities, their sleep, whether it is aggravating the sleep or whether it is relieved by sleep. So getting a descriptive, numerical, and site, all that on a regular, like every visit, it all depends on how frequently you're seeing the patient also. Sometimes what is done is, even if you can't see the patient in person, they do telephone calls, which we used to do a lot in Adair also. Because see, every time, because we saw patients from 2 ends of the country there. So we used to deal with calls continuously. We used to tell patients that they can call us anytime 9 to 5. So all these, see, you have to see what helps you. These are all basic, like we give you an outline, then tailor make it to your need and be successful. Not necessarily you have to stick to, you don't miss anything. That should be the aim or goal.
Thank you so much, ma'am.
Ah.
So there is Dr. Svetlana is asking, what about the visual analog scale and verbal descriptive scale? As ma'am was mentioning, I think you can use any scale depending on your setting. The most important part is that you need to get it from the patient, the score, and you need to be like thorough in assessment, and every review is important to document it, so that we'll know whether your pain relief is working better. You need to increase the dose, how long the pain relief lasts. So one single that proper assessment will give you the idea. So any scale you use, like in our setting, we use numerical rating scale, but I'm not telling it's the universal. But any scale you use, it's important to do a pain assessment. You need to get all the information. That's the key after all, whatever scale you use.
And then numerical scale is very good. Don't think as it's a gold standard type of thing. That is why, as I mentioned, they have done this numerical scale and then visual analog scale, and they have compared with so many studies, and they have matched 70 to 90%, they say. So don't think because it's so simple, it may not be good. No, it is still time tested. Even for morphine, we use the same. For example, you start someone on morphine, their initial pain score was 8. If they come down to between 2 to 3, something like that, that is a very good response. So we use that for when you're dealing with cancer patients and when you've started them on morphine, first review you do after 2 to 4 weeks. This is one of the guides we see. So it is fine.
Thank you, ma'am. I think with NRS, what we feel is like over the phone call, they get used to it and they say, oh, my pain is 4 now. Last week it was increased a little bit. So they get used to the numbers very common. So it's easier for us to document also than many other scales where you literally have to score something. Here you can just ask, how is the pain now? It was 8 before. You remember last time?
Exactly.
How much it is now? So
very useful. Clinically, we have seen it and found it to be helpful, so we continue with that.
Thank you so much. We'll do the case presentation and then we'll continue the discussion after that.
Yes.
Good evening, everybody. This is a very appearing to be simple case, but it is a very personal thing for me. And since I'm not practicing, I don't have access to too many cases. So I'm presenting something that happened to actually my daughter. So please bear with me if there are any, if it's not appropriate or not done in a very standard format. So this is about a 14-year-old girl child who presented with a severe headache, and she had some sensory and ophthalmic symptoms. Her case started with having a very severe headache from school, and she had to be picked up from school. After getting her home, she was treated with rest, water, and the normal paracetamol. But after an hour and a half or 2 hours, she did not improve. Her throbbing headache started increasing with head movements, and she started complaining of sensitivity to light and sound, and she said that she can see grayish flashes of light in front of her eyes. Slowly she said that she has a partial loss of vision and she could not see on the sides. Then after a while, she started, this happened in rapid sequence, and she complained of tingling and numbness on one side of the body. She was not able to speak clearly. Her sentences were not coherent. Her words were jumbled up, even short sentences. And then she started getting a heavy feeling in the arms, and then she was taken to the hospital. Next slide, please. For the history of illness, she hadn't experienced something so severe earlier. She had had a very intense kind of headaches in the past 1 year, which lasted for 4 to 6 hours, but which were relieved with rest and paracetamol and hydration. It appeared both the times that it happened in school when she was playing out. So that was something we could relate to the outdoor sun factor. Next slide, please. She was taken to a neurologist in a big corporate hospital where the neurologist was actually kind of in a hurry and did not examine her properly. And he said that it could be migraine, but since she has so many sensory symptoms, he advised an MRI, MRI brain with contrast, because her sensory symptoms were increasing. So everybody was quite in a state of panic that time. Next slide, please. After the MRI, brain was done, which took quite an amount of time, because from the starting of her symptoms to the MRI being done, actually 8 to 10 hours had passed. There were no significant findings on the MRI, and we took her to another neurologist because the current neurologist who had advised MRI brain gave us some sedatives, and we had to take her to another neurologist because her pain wasn't decreased at all. The other neurologist made a diagnosis of migraine with sensory symptoms, and he gave her ergotamine and caffeine tablet, and with 2 tablets in half an hour, she felt so much better. And it was a big relief for our entire family. Next slide, please. The psychosocial aspects of this. So even if this is a case of acute pain presentation, which lasted for 10 to 12 hours, it would, I think, would have a very strong impact, because she was a young girl, not experienced something like this before. She had lost sensation with intense headache, which was not being relieved. Nobody was kind of trying to even talk to her about it or do anything about trying to relieve her pain. She had a loss of sensation. She couldn't see properly. She could actually understand that her sentence is not being formed properly. So I think that is very scary for a young girl, or any adult also for that matter. Of course, her family around were also very disturbed. Since I said it's a personal thing, in spite of being a doctor, it's very scary to see your child going through something like this until you're really sure that it is migraine. And the psychosocial aspects, I think, don't only have an impact on the patient, but on the family as well. So like I said, in spite of having a medical background, even now when I'm talking about it, it gives me the shivers, because to see something that somebody has gone through that much, and in spite of knowing people and everything, it was quite an unpleasant experience for us. Yeah, next slide, please. So the medication which was given, like I said earlier, was tablet myelin, that is ergotamine and caffeine. After 10 hours of onset of severe pain, and we were asked to repeat it if she does not, if her headache doesn't subside. Of course, we were under observation till then. Till she felt better, we were in the hospital itself. And from then onwards, she's always been asked to carry it along with her all the time. And if she were to have any kind of sense or anything, to take it immediately. Next slide, please. Next slide, please. So I think the main concern here was severe, intense headache, which was acute onset and was treated pretty delayed. And the sensory and ophthalmic symptoms added to the concern a lot. Next slide, please. So the summary is migraine with sensory and ophthalmic symptoms in a young girl of 14 years. So according to me, I think these are the important points. How should this acute pain have been assessed? How could we classify this pain? And should pain relief have been given priority and importance before the investigations and the final diagnosis? Should the patient and the family be given some support and explained the severity or the situation to decrease their anxiety? And if the tried and tested crocin, as everybody gives at home and come, is ineffective to relieve the pain even to a little extent, was there a possibility that something else could have been given to at least decrease the intensity of the pain before going through all the investigations and the final diagnosis being made? Next slide, please. Yeah, thank you so much for hearing me.
Thank you, Dr. Mistry. I'll wait for a few minutes to get some response from the participants. What do they think about the management of this pain, specifically the assessment and how to classify, because we just heard how to classify this pain. So does it come under any of these classifications what Dr. Radha was mentioning, or like what could have been given before the final diagnosis of migraine and migraine is given? Yeah, Dr. Arnab has sent a chat that for sharing your personal experience, and the it's painful and never truly disappear. Thank you. Thank you, Dr. Manjari, for sharing with this group. And it's, yeah, I think it's a learning for every one of us, learning from a personal experience. So I'd like to hear from participants how to, I know that in a typical palliative care setting, you may not come across these kind of scenarios, but we do in our place, many a times we do get referrals for pain, and then some people get to know about pain management, and then they come to us with, very rarely we come across these kind of situations. So it's important to understand how to go about it. Yes, Dr. Arnab.
No, I didn't choose this with the palliative care setting. It was,
Yes,
the topic was introduction to.
Yes, yes. Yeah. But I was telling, yeah, I understood. But I was telling, we do get such patients in our set. Sorry.
I chose it related to the topic, not for palliative care.
Yes, understood. Understood. Thank you. Dr. Arnab?
Yes. So I wanted to share this one thought that I think what I understood from this sharing is that it is very important to speak to the patients about the process, the diagnostic thinking, and the work view that we go through, even while we are waiting for investigations or we are waiting for a proper diagnosis. We can actually comfort the patient saying, this is what we are thinking, and these are the tests we are going to do, and based on the tests we may be able to tell you for sure what problems you may be having, but at the same time address the felt need of the person at that moment. So I think it was very evident that the first pain medication was given almost 10 to 12 hours after the symptoms started, but maybe it could have been dealt as they come in a most, like whatever is the most protective or a safe medication to give, and then talking through a person who is experiencing something new, maybe a good thing that we can learn, that I learned, is that to talk through the diagnostic process, to comfort them, and to hear their felt need at that moment is something that we as doctors should do even before a diagnosis is made. Thank you.
Thank you so much. That's a very interesting, I think there are a few comments also. Should we actually focus on pain management even before the diagnosis, or should we focus on investigations to come? Many a times we come across this, like very early referral to our setting. Many a times the diagnosis is not yet made. They'll be still under discussion. And then they tell us like, we are yet to make the diagnosis. So it's just wait. So what do the participants think about it? Should we start doing the pain management even before any investigations, address it then and there, and then carry on the investigation simultaneously, or just wait for the investigation reports to come? I'm very interested to know what do you all think? Yeah, I think we have a very young participant from somewhere who is responding to the questions. Yeah, so there is a proper communication is the key is one comment that we have got. I totally agree. I think Dr. Arnab was also telling that to talk through the procedure or the investigations are very important. And Dr. Mrinalini is telling that pain relief should be given first. They should be comfortable for further investigation. Many people, yes, pain should be managed first. Yeah, assurance to the family. Offer pain management based on the most probable diagnosis on the first impressions. Yeah, wonderful responses. Like many a times, I think the question comes when we start thinking about prescribing opioids. Then they feel that, okay, why can't we just wait for the investigation reports to come before we start talking about opioids? So yeah, that's one point where maybe we'll take it up for discussion when we come to the step 3 session. But that's sometimes the question we deal in that way, like when we are about to start opioids and when there is definite diagnosis is not being made, is it cancer or non-cancer? Then sometimes oncologists might be reluctant to start the medication even before the investigation. Dr. Yadav is telling this is something we surgeons face. Analgesic may mask before reaching the diagnosis. Sometimes it is a dilemma. Very good, valid point, Dr. Yadav. Yeah. So what about pain management masking the diagnosis? Dr. Radha, we would like to hear from you. That's a very interesting topic for discussion.
See, like we are not going to mask completely, but keeping the patient comfortable, because this is also a symptom. So the pathology as such, as his from his surgical point of view, is a common thing. Being an anesthetist, we have faced this all the time. But we are not going to give something which is going to take away the diagnosis or something like that. So keeping, for example, from this per se, even paracetamol, giving the correct dose, that is 15 milligram per kilogram body weight, is the one-off dose if you're going to give for pain. So inadequate dosing can be sorted. So if you give adequate dose, it will give adequate response. So supplementing with some NSAIDs. If see, as long as this all you can do various type of things, adjuvant management, all these are important to an extent, because if someone is going to be in agony, that is another important thing which is dealt in great detail nowadays is how the pain is managed in the first place has a big impact on chronic pain. Post-operative, immediate post-operative pain management is very, very essential. If that is not done properly, many patients end up with chronic pain. So the appropriate management, not overdosing. We are not going to dope them with something or like that. So adequate, appropriate management will be helpful and not harmful.
Yes, Dr. Arnav has shared an experience where when you lose the, when you do the pain management, when you do the give analgesia, then the in suspected appendicitis patients, because they don't get their McBurney tenderness, and that's the real challenge. I think we have surgeons here and the pain specialists here. And what would you want if your kid has appendicitis? Would you prefer pain management or would you want to wait for the McBurney tenderness? Yeah, that's something which I will ask myself. What will I want for my own child? I would definitely want a pain medication to be given, at least the basic analgesics, not going into overdosing or stuff, but something very basic, so that you will get a proper pain assessment. I think assessment becomes easier when you manage pain in the beginning. You get to know the patient better, you get the trust. There is another response in this case with severe headache. Red flags were being ruled out. So yes, important to do the investigations, but definitely pain relief, comfort, and communication should be the key. Yeah, totally agree. Dr. Yadav, would you like to add on something in the chat about like you see a lot of patients with preoperative pain, and you deal with the postoperative pain too. So we'll wait for the response from the surgeons. The confidence of a patient depends on the speed of relief of any symptom, especially pain. That's very true. Like I have seen patients telling, I have heard patients telling that they did so many things, but my pain did not go away. They did a lot of investigations, a lot of procedures. The disease has gone, but I still have pain. So whatever better treatment or the best treatment they got, even after the surgery, the pain is still there. I went through all these problems, all these long hospitalization and investigations just to get the pain relief, and it did not happen. Then what is the point in going through all this? That's a very, very common comment that we hear from patients. What if it has been a tumor and relieved by, sorry, I just lost the chat. What if it had been a tumor and the previous episodes had been relieved with paracetamol? Very important to communicate that once pain is relieved, that she has to go for image. Totally agree. Like, yes, investigations has to be there, but should we wait for the investigations to be complete before we start pain relief? Treating the cause of pain is very important than treating the pain, and saving the life is more important than treating the pain. Yeah. Any response to that? When it's about understanding the cause of pain than managing the pain per se itself, maybe the use masking the pain.
I think in our, I'm a family physician. So in our family medicine practice, we have something called red flags and yellow flags. So I think somebody mentioned in the group also that if there are definite red flags and yellow flags for red flags for clinical and yellow flags for psychological symptoms, sometimes pain could just be depression. So or pain could just be a UTI. So definitely we should do investigations, but to treat the patient's felt need, because at that point patient doesn't want to know whether he has a tumor or a stroke or just a migraine, or whether it's temporal arthritis. Patient wants to get relief from the pain. Is, I think, if we give the patient a choice, then I think they would always choose pain relief as first.
Yes, I totally agree. I think if you want to follow what the patient wants, then definitely they want pain relief irrespective of what the diagnosis is. Yeah, it's a wonderful discussion anyway. There are a few more comments. Yeah. Headache and backache are the most common and most difficult to diagnose and treat. I totally agree. I think in that way, any chronic pain, I think we struggle a lot to manage.
Just a little thing in that. That is
Yes.
why the latest technique of managing chronic pain is multimodal management only. So that has been time tested and proved that multimodal management is the only thing which will give you, as he said, this red and yellow flags are there for back pain. There are red flag signs, yellow. Most of the things have red and yellow flag signs. Best is to follow them and adopt a multimodal. In many places, what they have is, once you get to a state that it's chronic pain, it will be dealt with a team of 3 people minimum. The physician and then the psychologist, and it's a team, psychologist, physiotherapist, 3 together only manage any such chronic pain issues. If you do like that, it will be an overall, see, you will satisfy the patient. See, it might be a psychosocial or psychological element. Physio may be needed, muscle stress, muscle spasm, something may be the cause for it. So if you do this multimodal management, you will get success rather than dealing it in a one-way approach. So that is why multimodal management is the final goal for chronic pain management. It is proven now. Very many of the pain management programs are done in such a way. In-house programs, online programs, many things are there. So they will deal with all this. As he mentioned, if it is when it is picked up by all the 3 together, it saves the patient seeing 3 different people in one setting. So beneficial to the patient. Patients will be happy that everything is sorted in one place rather than running from pillar to post.
Yeah. Dr. Lindo is telling that we should treat the pain, but at the same time, we should also know at what point of the ladder to stop and reach a diagnosis first. And I think the ladder is not a very rigid ladder, and it is not just stepping up. It's always a stepping down there. It's a very flexible ladder. You can always step up, step down. You can just get off the ladder at any point of time. So yeah, very, very, very good response. Yeah, in Indian scenario, the patient would have tried grandmother's remedies, so we must check on that too. Yeah, thank you, Dr. Sanjay. Thank you for the wonderful discussion, and I guess a few points were conveyed in today's discussion. Is there any other question from Dr. Manjari, or any reflection or anything that you want to comment on today's discussion?
It was an interesting discussion indeed. I was just trying to bring out the fact, because in the first session also, what Dr. Divakaran also said is that our medical system has become very dehumanized, and the aim in palliative care is to kind of shift to the human model again. It's not that we have to be doing a course to human practice, but since it is really I guess it's important, and hopefully it does strike a chord with most of the people to at least give it a thought and try to sit back and think, because what happens nowadays in this very fast kind of world, it becomes we tend to sometimes unknowingly justify what we are doing as, you know, we are trying to save somebody's life. So it doesn't matter whether we talk to them properly or not, a minute or two for somebody or not. This kind of experience, I'm sure everybody has gone through it. When you do it for, like, I've had bad experiences far too many times to even be, and it makes me wonder that being a doctor, knowing people, if I have to kind of struggle and see to it that you get a decent kind of treatment for any reason, whether it is chronic, whether it is for a geriatric patient, whether it is for a baby, for everywhere, unless somebody is your really good friend and you completely trust them, it just doesn't happen. So it really makes me sad to think that somebody who does not have medical knowledge and who completely puts their belief and trust in the people they're going to, I cannot even imagine what a tough time they have, or so many times they just come home helplessly. It's just yesterday also when Dr. Divakaran said that everything has become very dehumanized, I mean, it's something which one can relate to so much. And it's something that each one of us has to really work on, I think. Thank you. But it was a wonderful response. Thank you so much.
Thank you so much, Dr. Manjari, for bringing in the personal experience. And I think at least most of this group totally agree that this was indeed a bad experience for you, and communication could have been better, pain management could have been better. So hopefully in the coming days, we can expect more and more empathetic doctors who will understand that pain has to be managed and communication has to be done. So yeah, let this be a beginning from this group. Thank you so much for that. Dr. Aisha, you had a question?
Hello, am I audible?
Yes, Dr. Aisha.
Hello.
Yes.
I would like to share a similar experience of that of an 18-year-old girl with abdominal migraine. So she's my cousin's daughter. So she has had a first episode when she was 6 years old, and a very good physician at the age of 6 years diagnosed her to have abdominal migraine. But when she came down to Kerala, and she has had these episodes. So what the thing is, her suffering is she has continuous vomiting. When she starts that episode, after a particular amount of stress, where be it her exam or anything, any stress, an overnight journey, she gets these episodes. And the thing is, she tends to get very scared of these episodes. So it has a very, like it's a psychological trauma to that girl. She's an engineering student now, but the way that for all these past years that she has lived through with that suffering, almost she gets those episodes every year, once a year. But the thing is, most of the physicians are not aware of such a diagnosis as abdominal migraine. So when she's brought into a casualty with this thing, so they nearly take it as, because she's a young girl, they take it as hysteria. That the girl is hysterical, or she has some functional symptom. And the trauma that the girl and the mother undergoes is like, you can just imagine. Because we know the history, we are aware that it is such a condition, but even the physicians tend to say that you have to be more bold or something like that. They keep the psychologists or psychiatrists are called. So we have taken an opinion on with a premium institute in the country, and they keep saying that the only thing that you can do is give antiemetics. Even the antiemetics won't work at that time. That's what we have seen. Only thing that helps her is sedation. So the mother keeps telling the emergency physicians that she has to be sedated and she'll be fine. If she sleeps for some time, she'll be fine. But they just won't take that for an answer. That is what we have been seeing since since the age of 6 years. She has been suffering like hell, and even the mother, what the trauma that she goes through every time. That that I just wanted to share the experience that there is something called abdominal migraine similar to this, and she's mistaken every time.
Thank you so much, Dr. Aisha, for sharing that experience. Yeah, that's a lot of things to learn from today's session, a lot of take-home messages. And I mentioned in the chat, very strong advocacy for better pain management and better communication from us as doctors, from Dr. Manjari. Thank you so much. I hope Dr. Manjari will have a better time today, because it's so heavy for you. It must be so heavy for you to share this experience in such a group and having a discussion based on that. So thank you so much. Thank you so much, ma'am, for being a part of this program and taking a wonderful discussion. And I know that you have to join another session at 6:30. So just winding up soon. Thank you so much for being with us for last 1.5 hours.
Thank you very, very much. It's been a good opportunity to be with all of you. And it's kindled a good discussion. And everyone will have some form of change in their own practice. So that's what ultimately we all want. We all want to succeed and be better, sympathetic and empathetic, and for the patient and for ourselves too. So hopefully it all gets in the right direction. And thank you once again to one and all. And thank you for giving me this opportunity. Thank you.
Thank you, Dr. Radha, for joining us and guiding us through the introduction of pain in such a subtle way. I believe that the entire session was a really eye-opener for everyone, with the Dr. Manjari sharing her own experience and Dr. Aisha adding to that. So